So, Ani, you're in the middle of my screen.
Sure,
You start.
I'll start.
Sure.
Hey everyone, Rudy, what's up?
Yeah.
Ani from LA, stranded in my house for 2 weeks. Had to first close my office. So, but it's allowing me to actually set up my online business that I've been working towards for a little over a year, like online courses for pain relief for for massage practitioners. And so it's exciting, love it. Happy to be here.
Awesome. How about Rudy? Why don't you go next? You're next on my screen.
Sure. Hi, everyone. Rudy Hunter from upstate New York. For me, it's business as usual. I work remotely for most people and animals, so business is still going, even though everyone's freaking out. And lockdown in New York is always entertaining, but thrilled to be here.
Yeah. Jeff, why don't you go next?
Jeff Moyer. I own a private training facility here in Pittsburgh, Pennsylvania. Kind of on hiatus right now due to everything that's happening. So looking to study and learn, and yeah, figured I'd see if we could talk PRRT.
Yeah. Well, this is your idea, so we're glad that we got a good response, and hopefully if it works out, we can continue doing it. So
yeah, this is cool. Thank you.
Yeah, you're welcome. Danny, why don't you go ahead?
I'm Danny Haas.
Danny.
I'm Pi.
Well, we have two Dannys. Sorry.
Okay, sorry.
Why don't you go with the better looking one first?
Yeah, ladies first. Why don't we?
Ladies first. Ladies first.
Sorry.
No.
Danny Rodriguez in Washington, Eastern Washington, and I too had to close my practice. So yeah, that is something. But just excited to be able to see all your faces. Thank you so much for having me.
Yeah, of course. Thanks for being here. How about you, Danny?
Oh, hey. Hi, Danny, by the way. Hi. Danny Haas of Louisville, Kentucky, and unfortunately, we've had to close our practice as well. So I just talking to Eric today, I said, this will be a great time to study, and he says, well, we're going to have a conference tonight. How about you join? So that's why I'm here. So
yeah, thanks for being here. All right, Alan, you're next.
I'm Alan. Live out in Idaho, but I do my wizardry in the interspace. So it's really good to be able to help people from a distance without touching them and talking to them and all that kind of stuff. So it makes PRRT a little harder, although you can mentally do PRRT as well. So
sure, yeah. Pedro, you want to share?
Sure. I'm from Burlington, Ontario, Canada. I had to close the practice as well. Tried to do some work with some of the young tennis players I developed the programs for. But other than that, time to read, relax, and take it day by day and enjoy it.
Yeah, Pedro was supposed to be here. You were supposed to be on a plane going home yesterday.
Yes.
A program. Yeah. So,
was very fast.
Yeah. So too bad that we couldn't have you out. But how about you, Roger?
What's up, buddy?
Hey.
Can you hear me?
Yeah.
I'm down here in Macon, Georgia. We just got shut down yesterday for all massage and manual therapy, hands-on work. So, excuse me. Other part of the business is still open and going, so we're trying to make do with what we can.
Yeah.
I see old Pedro, the immortal one.
Hey, immortal, how are you? Immortal back.
Oh.
Well, thanks for joining us.
Absolutely.
Yeah. Jess, can we hear a little bit about you?
Yeah, Jess Langbart in Jacksonville, Florida, strength conditioning coach, and right now killing time without very many athletes.
Yeah. Cool. Well, we're 5 after 8. Maybe Dad, you want to say hi to everybody and do a couple of thoughts, and then we can jump into some questions and see if we have any stragglers.
Sure. Well, hello to everyone, and welcome to the call. This is something we've never done before, and it's something we felt fit the times that we're in. If you think about coronavirus, and abbreviated as CV, Vonnie and I have known about CV for decades because we both were raised in a city in San Diego called Chula Vista, and it was abbreviated as CV. So for us, the initials, bring back memories of where we grew up and where we met. Well, what I wanted to do tonight, if I can, is to try to give you some insights from my experience about what might be a helpful way to navigate what we still don't know exactly how it's going to work, the future of practice. So that's part of what we want to do. I've got some questions that have been submitted, and besides answering those, if you have any questions that you want to pose to me, I'll try to answer them and try to make it educational, as well as hopefully of value to you in terms of thinking how you're going to reposition yourself in the future as things start to turn around. One thing I want to really emphasize is I believe that there's going to be a tremendous pent-up demand on the part of people in pain to be treated and to get relief once we're allowed to socially interact with each other. And in the meantime, it's possible that you could offer services to people if you wanted to work with them on the internet, where you would show them some techniques that they would do and see if that would help them with their pain. And again, that's something you have to decide how you'd want to position yourself to do that. But obviously, it's possible that you could be helping people even without being physically present with them. It'd be like some of the home exercises that I've given you in the training that you could give people. And obviously, some of those could make a huge difference with people. So that's worth considering. Eric, I've got a note here that says iPhone on the screen.
Oh, I think that somebody just joined with audio, I think. So.
Okay.
But it looks like Pam Wilson just joined us too.
That's correct. Hi, Eric. Hi, John.
Hey. Hi.
Hey, Pam.
Hi, Pam.
We were just doing a little bit of intros. Maybe Pam, do you want to tell everybody where you are and your background?
Oh wow, I just lost the video. Can you guys still hear me?
Yep.
Yes.
Okay. The video's back. I'm an osteopathic physician, and I have 2 board certifications, one in radiology, one in osteopathic therapeutic medicine. And up until fairly recently, I was doing both modalities, and then I ended up getting sick from mold toxicity and had to close my manipulation practice down, and I've only been able to recently start doing a little bit of radiology again. Mostly I'm learning all about detoxifying my body, which is an interesting adventure.
Great. Yeah. Well, thanks for joining us, Pam. It's been quite a while, so we're happy to have you.
Thank you, Pam.
So it looks like we probably got as many people as we're going to have for tonight. I was hoping that most people would be able to address their questions directly to Dad, but I've got a list of questions, and what we'll probably do is go through those, and then I'll open it up. We can do kind of a casual Q&A for everybody else that has any topics or questions. First up, since we have Jeff, we reached out to one of our therapists who is a guru on lymphatics, and he couldn't make it, but I know that you wanted to have a discussion about lymphatics, so do you want to just pose it to Dad?
Sure. You know, just with everything going on with viruses and the flu and everything with the immune system, the role the lymphatic system has as far as immune health and drainage and stuff. Just curious. I mean, I know we do the water wheel and there's the lymphatic priming, but just curious, you know, if there's more that, you know, that you get into, or, you know, just kind of your overall thoughts on it. Because I've never, I don't know, when we've done the courses, it's been talked about, but never really into detail. So just kind of curious, John, since I have the forum to actually ask you, sir, your thoughts on the lymphatic system and doing work for it.
Well, you know, first of all, I think we have to realize that the lymphatic system is underappreciated and underevaluated and definitely undertreated. And so many people have that as an issue in terms of a piece of the equation of what's going on for them. My work on the lymphatics started from Edgar Casey's research, who was, you know who I'm talking about, Edgar Casey? Edgar Casey was a rancher or farmer, I'm not sure if he was both, down in the South like 100 years ago. And he would go into a trance-like state, and it'd be like he's asleep, but he wasn't really asleep, he was in a trance. And he would have the name of someone, and that's all he would have. He wouldn't have any information about them as far as what their symptoms were or their diagnosis. And he would come up with a protocol for them, and he was able to get results with patients that no medical doctor at that time could help. So his work had a great deal of emphasis on the lymphatic system. Most people he found who had chronic issues had a lymphatic system that was backed up. And so he felt this was a big piece of the equation. So some ways to facilitate the lymphatics, obviously, are to work on the thoracic duct, the left thoracic duct, which we've taught in the seminar. You remember that one? Okay.
Yes, sir.
The other thing is the diaphragm. So many people who have thoracic duct issues or lymphatic issues, their diaphragm is in a splenic protective mode from stress, usually, could be from an accident, from an injury. So you want to reboot the diaphragm. And do you remember which ribs we checked to see if the diaphragm is involved? Which ribs would we examine? Okay.
Is it the right side?
Well, you could check both sides, but it's ribs 6 through 9.
So next 6, 9, yeah.
6 through 9, okay? Because the diaphragm attaches from 6 through 12, but it's 6 through 9 that are the ones that are the most dramatic in terms of palpating. And what you're looking for or feeling for is crepitus. And also, usually there'll be a withdrawal reflex the person will have. Now, they may feel like it's ticklish, but if you go back and do it a couple of times, it's not ticklish. It's that they have crepitus in the ribs where they're attaching, the diaphragm is attaching, and you can go ahead and reboot that. And one of the easiest ways to do it is just to have them turn their head to one side, let's say to the right side, reach down with the left arm and cough, then reverse that, and then go back and recheck. And usually you've rebooted the diaphragm. And that may be important for them to do on a regular basis. Eric, I'm not sure when it says iPhone, can they still hear me, or do I wait until we get visual back on?
We can hear you, John.
Okay.
Yeah.
So again, the other thing is to push fluids when the lymphatics are backed up, and the herb that is world renowned for lymphatics out of the Amazon is Podiarco, P-A-U, the letter D, and then A-R-C-O. And that herb is a traditional herb for enhancing lymphatic drainage, Podiarco.
Hey, John?
Yes.
Do you mind if I add something while you're on the diaphragm?
I not only don't mind, I insist that you add, Alan. That's why we have you on.
So one of the things we've been doing a fair amount of research with the lymphatic, priming the pump and
Yes.
ankle sprains. And so we have one that's ready for publication now. And it's worked amazingly well with lateral ankle sprains.
Really?
Oh yeah, definitely significant results. But one thing that we've been doing in addition to getting the diaphragm active is we've been encouraging, once we clear the diaphragm, to use big abdominal breaths, not only on the inhale, but on the exhale. Really, once they finish the exhale, really pulling the abdominal muscles in and trying to squish down the abdominal contents as much as possible.
Okay.
And sometimes they can do that while they're in a flex position. So like sitting bent over their knees and then belly breathe. And that adds to the pumping effect that we can get in the core, because you have those big lymphatic channels or vessels in the core, but we generally don't get enough compressive force through our thorax in our abdominal area specifically. And so if we could free the diaphragm, that's great. And then once we get the diaphragm moving, if we can use that in a bent over way to stimulate it and get more of a pumping action to help those smooth muscles that are in the trunk.
That's a great protocol, and one that you and I should be working to put together in a written form, step by step type of thing, because it sounds like it would enhance what's going on. The other thing, of course, with the diaphragm is remembering that the psoas major has a great deal to do with the diaphragm in the pelvis. So you might want to also be sure the psoas major is not an issue, because that could be playing some role in terms of what the diaphragm is willing and able to do, because the fascia of the diaphragm extends into the pelvis and attaches to, and the two tendons of the diaphragm cross and attach at the anterior bodies of L3-4. Okay, so that's another piece of the equation. Yes, Ani. Hi.
Is that me? Hi.
That was my hi to you.
I just want to add something to what Alan said. As a medical massage practitioner, I do a lot of lymphatic drainage alongside with the pain relief, because it just has such a huge impact on your overall health. And when Alan mentioned with the sprained ankle and stuff, and one of the things I use a lot of Taoist healing, and when it comes to after releasing the diaphragm and then working on pumping the venous blood. So around, as he was mentioning with the pumping, you can actually teach patients how to compress when inhalation and exhalation, compressing, but also doing where the aorta is on the left side of the belly button, and then also doing on the right side for the venous blood pumping. But also you do where the groin area, where we have our major lymph nodes, a lot of lymph nodes. In a Taoist healing, they call it opening the wind. That opens up a lot of blood flow and meridian flow going down to lower extremities. So there's a way of actually doing a gentle pumping in a groin area where you feel the pulse. And that's been really, really helpful. I use that a lot.
That sounds like a great training we should have you do to get like a 5-minute video showing that, because not everybody's going to be writing everything down as you're saying this. So we should talk about that.
I'm actually working on, since I've been working on creating some online courses, I'm working on doing like a short educational videos.
Okay.
So once I'm allowed to get closer than 6 feet to a person, I can actually maybe get some volunteers, local. We have a couple of people in LA that has gone through PRRT, like maybe Marlena, and maybe she can come to my office and we can videotape it as I'm doing on her.
Great. No, that's great. Yeah, that's a type of training that I'm not I've heard of it, but I'm not familiar with the protocol. So that would be interesting to.
It works really, really good for lower back pain also.
Mhm.
especially if they have any large intestine, like constipation issues. It works tremendously because it causes so much lower back pain.
Gee, I mean, do you think lower back pain is something we see very often?
Once in a while.
If it could influence low back pain, which of course is the #1 reason patients go to physicians, primary care physicians, from on the pain side of the equation, that could be a nice, that might be a game changer. Yeah.
You know, one of the other things that we talk about with the lymphatic system is the neurolymphatic reflexes, or the Chapman's reflexes.
Mm-hmm.
And the theory used to be that they were associated with particular organs, and stimulating those caused the organs, or the lymph around the organs, to release toxins and those kind of things. And I don't know whether that's true or not, but I do know that they're definitely seem connected with the muscles that they have relationships with. And also the organs from a meridian standpoint seem to function differently. So the Chapman's reflexes, and they've kind of expanded on that in like Eden energy medicine, but the lymphatic system is probably one of the, between that and the fascial system, probably the two most underestimated systems in the body.
Yeah, very, very good, Alan. Yeah, the Chapman reflexes are a big part of the osteopathic approach. Osteopathic physicians all are trained in the use of the Chapman reflexes.
Yeah, that's correct. And if you wouldn't mind, I can make a comment on that if you'd like.
I not only would like, I would insist.
All right, then. So I use the Chapman's reflexes, and probably not quite how most people do, but the neurolymphatic use of them, or when I'm wanting to manipulate an organ, is very, very useful. So for instance, if I have a restricted kidney I want to work on, if I work on the neurolymphatic portion of the Chapman's reflexes, both anteriorly and posteriorly associated with the kidney, and stimulate the body neurolymphatically first, I can get a lot more rapid and a lot more complete release of the kidney if I treat that after I treat the Chapman's reflexes. And in fact, I use them modestly frequently because I actually look at lymphatic drainage in a fair number of my patients, because it's warranted in a huge number of people.
So given what you just said, do you tend to find that people would tell you that they need to get off the table and go use the restroom after you've done that because you've liberated the urinary system?
Yeah, they do tend to need to do that, but I think in general that tends to happen because as I'm doing manipulation on a person's bodies and tissues, the lymphatic system is going to be engaged whether I'm directly focusing on it or not.
Right. But now that we're talking about that and your background as a physician, with people who have the coronavirus, which we haven't talked about yet, who recover, in theory, they recover, but they have what may be some lingering problems. Would you expect that some of that may be tied to the lymphatic system not functioning ideally for them?
Right, I certainly would. And not only that, but I would expect that part of the mechanism that allowed them to become sick to begin with would have to deal with the fact that their lymphatic system wasn't working well and clearing. So we had a very good discussion by Frank Willard, PhD anatomist at the main osteopathic. You know him, okay?
I know who he is. He's world renowned.
Well, that's part of the reason he's easy to know about. But he gave a 6-hour presentation all on the lymphatics a couple of years ago. And basically the idea that we've all been taught that osmotic pressure pushes fluid out into the capillary bed, and then oncotic pressure brings it back into the capillary bed, he says is absolutely incorrect. And it makes sense that it wouldn't be correct, because if we push the fluid out into the capillary bed into the interstitium, then we're going to drag, diseased portions of the cells, bacteria, viruses, back directly into the bloodstream. And he said, really what happens is you push that fluid oncotically into the interstitium, and the lymphatics pull it out and not only concentrate it, but bring it through multiple series of lymph nodes where it's interrogated, and anything that's an antigen then starts stimulating the cascade of the immune system. So by the time it actually gets to the lymphatic duct, it's not only extremely concentrated, but that it's had multiple opportunities to stimulate the immune system to respond to any antigens that are present. And so if that lymphatic system isn't working well, none of that system is going to happen. And they're not going to get that multiple tiered stimulation of the immune system as we're designed to have.
Yeah, and
pretty important piece with what we're dealing with now with the coronavirus, what you're talking about how the lymphatics may be playing an important role.
Yeah, what's interesting about that
is that work of Dr. Willard, is that available somewhere? Do you know?
I'm assuming that it is. I don't remember his references specifically, but if you've ever heard him speak, he has references for everything.
Yeah,
and
I think I know that already, that he's very much into that. Yeah.
Yeah, and so I know that some of the references I know with certainty, because they actually had some, I don't know if they were electron microscope, they were very fine-tuned things. So the lymphatic channels are not only thin-walled, but actually have one-way valves in them. And so they would fill up with fluid, and then they would allow this escape of fluid forward. And then the valves would collapse back to prevent the fluid from coming back into the more distal portion. And that actually acted as a pumping action from the lymphatic vessels themselves. So he had some video of that, and it was absolutely beautiful to watch.
If you have a link on that you could send me, then I could share that with our group here.
What makes it even more important is if we have the basic breakdown of tissue after an injury or a disease state is a free protein. And what's interesting is the free proteins are too big to fit into the venous capillaries. And so because of that, they have to go through the lymphatic system. And so the number one way things move through the lymphatic system, especially in the extremities, is muscle pumping. By far the best way. And so if we're not getting enough activity, or we're not getting enough muscle pumping in that region, or frequently enough, or like you've figured out that there's points where it tends to get jammed up where we don't think about it, like in the hips, right? That we just don't think about that. And it seems to be an area that's really easy for it to get blocked in.
So a couple of other thoughts, just because we're talking lymphatics, and I think that's a huge topic given the issue the lymphatics are going to have with the coronavirus for people who unfortunately suffer from that. One is that mini trampolines where people would just bounce up and down, they don't have to be vigorous with it, seems to help facilitate lymphatic drainage. Another is based on the work of Edgar Casey, where he would have a castor oil pack that he would have people use, which was a heating pad over the abdomen, where you would put castor oil on the skin and then wrap yourself up with like a blanket. And there's videos online if you were to go on the internet. This is something that was one of the big pieces that Casey felt in terms of his belief that the lymphatics were playing a huge role in the majority of people that he was doing a reading on.
Well, Dad, I know that at one point you said diaphragm and psoas is something critical to double check, and we're lucky to have one of our instructors, Tom Krupar, just join us. He wanted to know why those two are so important, in addition to the SI, and do you have an order that you like to clear them in?
Are you there, Tom?
I am. Sorry I'm late.
No problem.
That's all right. At least you made it to the party.
That's right. Better late than never.
Better late than never.
Yeah,
I don't have an order for it, so it's something that I would just be checking. My sense is the psoas major, not the minor, but the major, has a very strong autonomic influence because of the lumbar sympathetic chain ganglia that actually penetrates the substance of the psoas major, not the minor, but the major. So I think that it's because of this very unique and very primal innervation that the body is designed to have the lymphatic system be able to influence this area. And obviously, this is the only place in our spine that we have muscles attaching directly to discs, as we do in the lumbar region, that not in the thoracic, not in the cervical. So, I mean, it's an area that I think needs a lot of drainage, and I think that's the reason that we were gifted with the lymphatics being extensive. There was a series of talks that were being given decades ago on the lumbar spine, and I remember one of the talks, one of the surgeons who had done some extensive dissection had found on cadavers that there was really a tremendous amount of lymphatic tissue in that region, in the lumbar region, and it had not really been appreciated at that point that the lymphatics were as prominent as they were by his research. By the way, when you all see people, as we start seeing people back in the future, I think the lymphatics would be one of the most important places for you to start, especially if people have had any amount of issue with coronavirus, even if they didn't have a serious case, just even a minor case. This is something to check because it very well could be part of their symptom pattern.
Yeah. I have a couple more questions from Tom that I want to go back to, but I think it's probably a good time to discuss the trigeminal downregulation that Rachel Henderson was asking about.
Mm-hmm.
She said there's many options. Which do you prefer to apply to patient in session versus teach them to perform on themselves? Is there a tweak to add or modify if the patient doesn't downregulate in 30 to 90 seconds?
Let's see how to take that. First of all, I don't know what Rachel is saying about where she would be assessing them for downregulating. Normally, what we're looking for with the trigeminal downregulating maneuver, which would be to place the thumb underneath the mandible, and you're halfway between the mandible and the bone in our throat there. I'm trying. Hyoid bone. Sorry, thank you. Anyway, so you're there and you're saying to the person, I want you to gently try to open so that they just barely feel tension in the thumb as they're trying to open. And what that does is that'll reciprocally inhibit the muscles of mastication, which would be primarily the masseters and the temporalis. So you teach that to them and have them do that at the same time that you say, I want you to fill your mouth with saliva, pretending vividly as if you're sucking on a lemon, because we know that if you fill your mouth with saliva, based on research out of France, that you're going to have a parasympathetic response. And this is so important that when you teach this to people, even if they only do it at night before they go to sleep, you want them, when they come in to see you, you want to check them by going cross fiber to the masseter and the temporalis and see whether they've got NSRs or trigger points. If they have them, you have to question whether they're really doing their homework, because if they are doing their homework, the only other thing that could be causing that would be that they're resetting it before they go to sleep, and they still may be clenching and grinding during the night, which means they need to do the maneuver also first thing in the morning to set it in place for the rest of the day, so that they're not carrying forward tension that they held in the muscles of mastication during the night.
Yeah, I mean, I think this would be, Alan, you got a point, but I mean, if you're able to send it out to your patients and clients now while they, if you have to send them a home video to kind of work on while they can't come in, right? I mean, I think with everything that's going on, it feels like there's just, the next shoe that's going to drop. So I'm sure there's a ton of people that are walking around I can feel it myself, that need it.
So yeah, I mean, I agree with all of that. And I usually use the favorite food ever. Like you're about to eat your favorite food ever, which gets your salivary glands going a little more than your parotid glands. But you could use either and just see which way it releases. But the other thing I was going to say with that is, as you're releasing that and you're doing the trigeminal down regulating maneuver, give them permission to let go of all the things that they've been chewing over, all the things that they've wanted to say, that they've held their tongue on, or that they've been holding in, or they've been biting their tongue on. And as you do that and you hold them in that position, you're giving them permission to release one of the underlying reasons why we hold tension there is because we're either chewing things over, or we're biting down on our words, or we're afraid to express ourselves. And so if that's not addressed while you're doing it, and that's one of the causes for them, then you can release that all day, every day, and it's still going to be a problem because the driver is emotional or mental.
Good point,
So,
Alan. Yeah, very good point, Alan. Yeah, those are, yeah, I mean, the dentists will tell you that they find the majority of people that they do work on for dentistry that the people have this tension in their jaw muscles. They hold the tension there. And that's why they make mouth guards for so many people. If you ask everyone you see from now on, do you wear a night guard for grinding, clenching your teeth? You'd be surprised how many people say that they have to wear something. That should not be. I mean, I'm 74 and I've never worn one. I don't ever plan to wear one, and I don't grind or clench at night. So I just think it's not a normal thing, and it's unfortunately such a common thing that we just stick an appliance in their mouth and hope that that's going to fix them, but it doesn't really fix them. That's not the solution. If you quiet the muscles of mastication, there'll be less tendency for people to clench and grind their teeth at night. And the other thing is, what's the important mineral for people to take for muscle relaxation?
Magnesium.
Magnesium. So if there's a time to take magnesium, it would be at night, if they only take it once a day, or they go to sleep at night, and then have that be working throughout the night to help with quieting the muscles of mastication, and also helping them to get into a deeper REM cycle of sleep, because sometimes the clenching and grinding is associated with people who aren't in a deep REM cycle of sleep. They're kind of struggling in their sleep pattern.
Well, I'll let Rachel discuss more further with you if she wants, but I'm glad we got to touch on that. One of our other instructors, Chuck Renner, was asking if you have any feedback about the pain and dorsum of the foot.
Two things for pain on the dorsum of the foot. The most common thing I find is a small little muscle there called the peroneus tertius, and that's the little hump on the top of the foot that we have. That muscle, if you go back and forth across that on people, you'll feel crepitus quite commonly. So that muscle can be having a trigger point in it. And to reciprocally inhibit that, you have them just take their toes, curl their toes down, you go underneath, and then you flick the toes up at reflex speed. So you're firing the flexors of the toes and reciprocally inhibit the extensor digitorum brevis, okay? And that usually makes a big difference. If that doesn't, then you want to go back and assess the tarsal the tarsal joints, the intertarsal joints, and see, go to the foot that's not having the symptoms and feel the motion there. And there may be, and the navicular seems to be the one that's the bigger culprit more often than not. So you may want to do some work on getting motion in the navicular. So that's how I would approach it.
Okay. He also asked if C1 down regulation doesn't work, do you have any next steps as suggestions?
Yeah, You know, remember the upper cervical region, this is where chiropractors who do HIO and NUCA make their money because they do upper cervical manipulation and imaging. So it's a real common problem, but one of the reasons that it may not work is if, in fact, the person has involvement in the rest of the cervical spine where the spine is in a, if not a straight, it may have a reverse curve. So rather than have a near 40-degree anterior curve of cervical lordosis, they may have a significant reduction in it, and or they may have a reverse curve, especially if they've had trauma. Now, the trauma nowadays doesn't just come from car accidents, it comes from sports. So a lot of sports involve injuries to the head and neck. And unfortunately, many people never get an x-ray. All they need is a true lateral view to see whether they have the near 40-degree curve that they should have. And the other reason for a C1 problem is that the rectus capitis posterior minor and the other suboccipital muscles are in a facilitated state. And that's why the upper cervical chiropractors, the HIO and NUCA, do adjustment of only C1 and C2. But normally that's not necessary if you are able to downregulate the muscles of mastication and the cervical spine restored to anywhere near 40 degrees of a lordotic curve.
John, one of the things that has been helpful from a perspective with C1 is making sure that you release the SCM.
Mm.
And
Good
a lot
point.
of times if one side's restricted, and you'll see that in the old flexion rotation test where you flex them maximally,
Mm-hmm.
and then you rotate them to the right and to the left and see if there's a restriction.
Yeah.
And so you could fix C1 first, but make sure you get the SCM. Or sometimes you have to fix the SCM to allow the C1 to be released without added excessive pressure. So
That's a good point. And let's remember that the SCM are the primary muscles for rotation, and half of all rotation occurs between C1 and C2. So, I mean, we're talking about a very primal level. And obviously, the upper traps in the SCM are innervated from a startle reflex standpoint, meaning that's how primally wired they are. So, good point, Alan. Really good. I appreciate you sharing that.
Teresa was wondering, I guess she's having trouble getting levator scap to relax. She said omohyoid responded well, but levator scap is being stubborn. You have any suggestions?
Yeah, again, we have to start also by looking at the upper cervical joints because of the attachment of the levator. If we have restricted motion between C1 and C2, and maybe even as far down as C3, that's going to cause the levator to be in a facilitated pattern, and it's not going to maintain improvement. So we have to make sure there's motion present, especially as we get to C1 to C2 because of the amount of rotation that has to occur there. The second thing that we're not normally thinking about is that the levator may or may not be also being facilitated by the omohyoid, because the omohyoid has a very important attachment that is very much integrated with the attachment of the levator. So you always want to clear the omohyoid to make sure that's not really participating and causing you to think the levator is the problem. The last reason would be if there's been some crepitus that develops at the superior angle of the scapula, you'd need to clear the crepitus, which usually you can get through fascial work to be able to have the superior angle of the scapula be able to glide without a sense of crunchiness there. So those are the things that I think are important.
Could I add one thing?
Well, you can add more than one if you want.
With the levator scapula, because I do a lot of intraoral releases. I mean, I have dentists refer me patients regularly, and the tongue release is amazing. I mean, once I do the intraoral release, specifically tongue release, a lot of the levator scapulae, all the suboccipital muscles like 80-90% of it is gone. And then after that, then I'll go and do more of per techniques for the subscapularis area. But mostly I start with the intra-aortic release and the tongue release.
That's a great point. And how often do you find that to be in patients when you're treating them?
Oh, over 80% of my patients that come with the neck pain, they have jaw clenching or grinding issues. And so I say 90% of my patients, I do intra-aortic release.
Good point. Yeah, very good point. That's a missing piece right there. What else do we have, Eric?
We have a couple of questions about promoting, but I think since we're on the topic of techniques, Rudy was wondering if you have 3 quick techniques for once we're no longer socially distanced that you can use at the bank or grocery store.
Well, that's an interesting question. There are times when I actually treat people when we're standing in line. I mean, I've been known to do it nowadays. You couldn't do that because you're supposed to be 6 feet apart from them. My favorites are, first of all, the SI joint, because when they're standing there, you can palpate their SI joints as long as you have permission to do it. And commonly people will pull away when you just palpate lightly over the SI joint. So that's one. What I typically do to treat that, if I'm going to do a treatment on them, is to just karate chop above and below the knee on that side, on the inner aspect of the knee, go back and recheck, and it's gone. The next would be the diaphragm, because obviously if you strum the diaphragm from ribs 6 through 9, most people are going to have involvement there. So I just teach them to do the head turn one direction, reach down with the opposite arm and cough. And that usually clears the diaphragm. And then the last thing would be if they're having problems with the upper trap or the upper ribs or both, where I would just come and have them flex their elbows to 90 degrees, push down lightly against my hands, and then I would lift up quickly at reflex speed, and that clears upper trap and upper ribs. So those would be the 3 when you are no longer socially distancing.
Thanks, John, glad I asked.
Yeah. Thanks, Rudy, for the question. There is a standing SI release too in your manuals. So
yes,
that one. Yeah,
I like that one too.
Yeah.
On the standing SI release, I usually just put my foot inside their foot so that they can be in slightly an abducted position with that hip, and then they just push on the outside of my leg. So I put my foot inside their leg so they can push at the same time that I'm karate chopping that. So it ends up being just like you do it on the table, where you create a little traction force by squeezing on the table. You could just do that with your foot and have them push against your foot. And I do a lot of these in the hallway at work, or in the clinic walking through. So or out at practice. So we've gotten creative with some of these alternate positions.
But Alan, you can get away with that because of your haircut. I don't think I could.
Sometimes.
Hey, John?
Yes.
I've got a question. With the levator scapula.
Yes.
Do y'all ever see, and everyone else here on the call, do y'all ever see any correlation between medial head of the tricep and levator scapula?
I have not looked for that, and so I don't have anything to add. Have you looked at it, and what's your experience with it?
I stumbled across it, and it's been one of my go-tos now that I look at the medial head of the tricep.
And you use the biceps? Do you use the biceps to reciprocally inhibit it?
No. I'm doing contracting the medial head.
Do you use the biceps? I'm sorry. Go ahead.
No, I'm using the medial head. So like I will have a mainly it works in the extension a shoulder extension, and then I'll see a release in the levator, a reset in the levator. Almost, I mean, I'd say 3/4 of the time, if not more. It cleans it
Can you be
out.
more clear on what is the maneuver you're doing that creates that release? Can you describe it?
Well, it's almost like a pressure point on the medial head of the tricep. And
Okay.
then I'll have them usually I have them in a prone position, and I have them do shoulder extension with the pressure point on the medial head, and the levator just melts, releases, resets, whatever verbiage we're using this day and age.
Cool.
I don't know if anybody else is. I don't know if anybody else has seen that or not, but that's what I'm seeing.
Well,
Eric, are we frozen?
No, everybody's still on, I think.
I do know one thing is a levator, Darth levator, to be one of those muscles that is dependent on other things in order to be released.
Right.
So you might try to release the levator and then you can't get it, and then you release 2 or 3 other things that seem to be also gone, and then you can come back and get the levator. But a lot of times the levator won't release on its own. It tends to be a very connected muscle in some way, and very reactive muscle.
That's what yeah.
Remember, the levator will fire with the startle reflex. When the shoulders go up, the levator is going to be firing as part of that shoulder elevation that happens in a split second. So it's very primally wired because of its attachments at C2-3. I mean, obviously, there's a tremendous amount of influence, but the medial head of the triceps as a release, that's a new one on me. I'm going to have to try that. I like that.
Give it a whirl. Let me know what you think.
Yeah. And again, I'm curious, because of your experience with it, do you find that doing the release of the medial head of the triceps, does that release the crepitus that's usually present at the superior angle? Do you find that that also takes care of the crepitus?
Yes.
Okay.
So when you're using that as a pressure point, are you using that, is it referring to the levator when you're pressing on that? Or is that independent? So like a trigger point, or is it independent of that?
Well, I've seen both. I've seen both. And this is what I've been wondering about. Probably should have reached out to John and everybody else much sooner, but I've seen both. We're just doing the pressure point, like the trigger point, causes the levator, the crepitus, to diminish.
Yeah, no, that's great. I'm anxious to try that. That's such a common pattern that we tend to find. But also remember that you may or may not need to clear the omohyoid, because that could still be playing a partial role in what you're finding, because that muscle also tends to have a lot of primal innervation in the way it's influencing.
Mm-hmm. Could you do a tendon reflex to release the tricep? Deep tendon reflex, right? John, anybody? Hello?
Who are you asking?
Bueller. I'm just the group.
Bueller.
Anyone?
The deep tendon reflex, can you do that on the tricep at all?
Have you tried it?
No, I'm asking. I'm asking, yeah.
Yeah, I don't know. I mean, I think when we start seeing people again, we'll have to try it.
Jeff, are you asking about deep tendon reflex to inhibit levator scap?
To inhibit the tricep.
Oh, yeah. Okay, that's what he was asking, Dad.
Yeah.
Yeah.
Okay. I don't know.
Yeah.
Could we speculate on why this might be happening? Like why there would be a connection between the tricep and the levator?
Anybody want to take a shot at that? Give me a few seconds to get my brain wrapped around that one.
I wonder if there's a fascial train coming up the ulnar side of the arm and going all the way up the back into that levator scapulate to the neck.
Like a kinetic chain.
That's interesting. Yeah, that's.
Well, a fascial connection, because we know that more of the force of a muscle contraction is transmitted through the fascia, and so that fascia interconnectedness is huge.
That's definitely sounds reasonable to me.
Yeah. Alan?
Well,
Absolutely.
my son was having levator scapulae issues last night, and since I'm sort of quarantined in house with son in our current situation, I think I've got a victim I can try this out on tonight.
Yeah. Let us know.
While we're talking about levator, let me make a couple of points. First off, always make sure you're not really dealing with upper ribs, particularly first and second ribs. I mean, because sometimes you think you got a levator issue, and what you really have is an issue with the first and second ribs, which you need to release. And once you release that, you go back and you recheck, and the levator isn't the same as it was before. So that's now the other option. If the levator is only involved on one side, let's just say it's on the right side, then what you could do is facilitate the levator on the left side, just reflexly, and oftentimes that will correct it. It'll balance the two sides out by facilitating the opposite side. Because if you think about the levators attaching at the lateral transverse processes of 2-3, what you do on one side will be perceived on the other side. So this, again, you can have, as long as you don't have a bilateral issue, you could go to the opposite side and create a facilitation, and that should create reciprocal inhibition.
It seems like levator responds best to the one where you tap and stretch at the same time. Because it's so proprioceptively driven and so startle driven that it resets that way better than if you try deep tendon reflexes.
Okay, good.
I almost wonder if that's not what this new technique you're talking about might be doing. It sounds to me that you're not really downregulating the tricep, you're stimulating the tricep, and therefore probably stimulating the posterior delt as well, and getting your reflexive reduction on the levator that way.
Well, that's a good point, because both the triceps and the posterior deltoid would have extension as their primary action.
Right.
So
Okay.
They would be synergistic from that standpoint.
Well, Dad, we're going to give you a break for a minute. Tom wanted to see if anyone has feedback about how they're marketing themselves. I know that this is a challenging time, and I don't know, Tom, maybe you want to discuss what you were thinking?
Sure. Yeah. I'm always, being a business owner, I'm always thinking about how we could put ourselves out there. Obviously we're talking to physicians. My brother and I are starting to try to get more out into talking to the professional groups, conferences and so forth, and, putting up the booth and showing them some techniques. But I wondered, is anyone doing anything else publicly to the general public or otherwise to try to get word out about PRRT and what we do?
I can add something. I don't know how I ended up with an advertisement for a company that does corporate wellness fairs. And so I get emails about companies that are looking to bring people in for a corporate wellness fair. It's the booth thing, but it's in a company with a captive audience that are, walking around. And PRRT is so easy to do in public. Nobody has to get undressed, They can lay on the table with their suit on or with, their corporate clothing on, and you can you can work that way. So finding the groups in your area. I think the company is called IAB Wellness or something like that. I
So
can,
this isn't the company itself. This is like an intermediary company.
yeah, it's a company that I guess they promote corporate wellness for a variety of companies.
Okay.
So it's kind of like the middleman.
Yeah.
So this kind of brings up something I'd like to put out to all of you and suggest that you consider this as we're in this period of uncertainty about being able to have people come to us for treatment, and also about the monetary side of the equation, which is also in question. So if I were you, when we are once again being able to be socially connecting, you might put out an initial offer, feel better in 3 or the third one's on me. I really think that nobody else is going to be putting themselves at risk, where you would see somebody day 1, you see them day 15 or day 14, 2 weeks later, and then you see them the last visit in that pattern of feel better in 3. You see them on the 30th day or so. In other words, you're spreading out the time, and you give them home program to work on, so they have the emphasis on what they need to be doing in between. And part of the deal needs to be that when they come back after the first visit, meaning for the second visit and the third visit, what you've taught them to do, they have to be able to show you that they've been doing it. If they don't remember how to do it, then they haven't been doing it, which that's their responsibility. And that's part of the deal, is that you're giving them homework that's part of their treatment, and that you're going to be asking them to demonstrate this when they come back. If you put it out there that way before they come back the first time, which would be at day 15, they're much more likely to follow what you're teaching them to do than if you don't say that you're going to check them on it to see how they're doing with it. So I really think some of the people that have contacted me, I've said, you know, when I'm ready to start seeing people again, when we're allowed to, that I normally only have to see people a couple of sessions. And I said, usually I see them day 1, day 15, and day 30 if I have to do 3 sessions. And they're not used to hearing that. They're used to 3 times a week. So you have a chance to come in and position yourself at a very fortuitous way when people are trying to get their life back together again, knowing that they will have pent-up demand for treatment, that they won't have been able to have anybody do anything for them. And so they won't have what they consider the money to pay you to be coming in for multiple visits in a week. So to the extent that you can position yourself that way, I think you're going to find you can put the word out to doctors' offices so that they know that you are the type of an option that may not be what their primary referral source is. Their primary referral source may have people come 3 times a week as their typical pattern. So kind of put that
I always
in.
give a money back guarantee. And I've
Sorry?
never had anybody ask for their money back. So I always start with that. Like, you know, if you're not satisfied in any way, the first visit, you can ask for your money back. And nobody's ever even come close to asking for their money back.
That's great. Good.
And it's something that works so fast. I also limit my evaluation, which is kind of an anti-healthcare thing to do, but I'm really careful to limit my evaluation, especially on the things that are, you know, half of our tests are provocative. So I'm really going to be careful not to do a lot of provocative testing, because they're not going to tell you much anyway. You know, I might do some tests just to confirm, but I'm really feeling with my intention as much as my fingers, because I don't want to inflame them when I'm trying to calm them down. And so the combination of those two things, you know, we should be able to make huge changes that first visit, and that gets people in the door, especially busy people.
Yeah, no, Alan, that's a great point, and the protocol that you're using, I think, is very important. Where you're not overly aggressive on your initial time with someone, because they're going to have, if they have prior experience with any other type of therapy, they may think this is kind of strange stuff. But going back to something I've taught you all, and you may not be thinking to do it because you're so into using PRRT, is you take the reflex hammer and you tap them on the elbow and you say, you know, is that something you had when you had a physical from your doctor? Oh yeah, yeah. Or they tap them on the knee. Usually it's on the elbow or the knee. And just say, well, you know, everything that we're doing is based on the same reflexes the doctor uses when they're doing their testing. So you're getting that validation of the doctor tied into your protocol. Other questions or other?
John, I just wanted to add just to plant the seed a little bit about PRRT, not looking just at the population of pain and post-trauma. I've been very successful and I continue to research more and more. We're working using PRRT as enhancing performance and injury prevention in athletics. And I work primarily, as you know, with tennis players, Tennis Canada, along with the baseball players in my pro leagues. And in the last 3-4 years, with tremendous response, with decreased injury over the years due to their performance, without having specific trauma to it. And I think we can market it to athletic performance and enhancement if we're not going to look to that extreme. And I think that population there is extremely open-minded to something that is not aggressive, it's fast, and gets them to perform better. I think we can go that way. I've gone that way, and I can tell you, it keeps progressing, become more and more receptive in that world, in the world of athletics.
And word of mouth starts to travel, doesn't it?
Exactly. It's very easy because it's a population where they will try anything to enhance performance. There's no issues. And the performance on the field, especially with tennis players, it's significant. Pre-tournaments, post-tournaments, how to get them to recover, teach them a few things to recover between tournaments. As you know, tennis in North America, there's not really in-season and off-season. It's in-season between outdoors and indoors competition. So teaching some of these young athletes, some of these PRRT approaches, you can see their performance on the field, on a court change. And to me, that's significant. I think PRRT should go that way as well, not just for pain and trauma, but also enhancement of performance.
I like what you're saying. Alan, does that sound like it resonates with you, with what you do with your athletes there?
Can I also make a point? Oh, sorry. Go ahead, Alan.
Oh, I was just going to say, I agree 100%. And athletes and professionals, they want fast, they want good, they want, and it's really cool because there's so much opportunity for research in those levels too. A lot of times you're having imaging before and after and all sorts of really cool things that you can do that you wouldn't be able to play. I also think that industrial settings where they're, corporate settings, industrial settings where they're just trying to keep people happy and healthy and feeling good, it is worth its weight in gold because it's fast and it's effective. And, you can see people in 10, 15-minute increments from a prevention standpoint. And that can be really amazing. So, yeah, I like it.
To pick up on what Alan was saying about corporate or businesses of any size, oftentimes they'll have someone who provides care for their employees, but there's a great opportunity to be a person who comes in and sees the people that don't respond to whatever care is being given. You're not trying to replace the other, let's say, therapist, whether it's a massage therapist or a physical therapist or a chiropractor, whatever. You're offering a different service, and you say, let me have 3 people on your staff in your business who aren't responding to what current treatment they've had, and they've had at least weeks of treatment, not just a session or 2 of somebody else's work, and then say, on the basis of that, you can evaluate whether I have something to offer. You'll be the only one going in that'll be saying that.
I offer up the integrative approach with the physicians and with the different physical therapists, chiros. and with the clients or patients themselves.
Mm-hmm.
Is my approach. And adding on with Pedro, what he was saying was about the performance. I work with a lot of CrossFit and a lot of powerlifting clients, and they go in and just minimize the amount of warm up that they have to do.
Mm-hmm.
To be, I mean, their muscles are ready, their nervous system is ready, and they love it. And like you said, John, word of mouth, then it takes off.
Yeah. Yeah, CrossFit has a considerable number of injuries that people complain of. It seems popular, but it's amazing how many people you hear who say, "I like it, but you know, I've had these issues with trying to continue to do it." So that's a big market.
Well, John, if I may say just something to add up, just a little bit to finish this. Very simple research I've done in the last 6 months with some of the tennis players, just using the primal pumping for lymphatic system and looking at serve speed. It's amazing what happens when they do lymphatic pumping for about 14 days in a row, and now they get more power on that serve. So just little things like that, which I'm trying to figure out by just isolating something to see how they feel. And now the body recovers, but it has a tremendous impact on their performance. So it's just to reinforce the fact that it's an amazing tool to have. And when they see this happening, it spreads like fire. Like, you know, I started doing this research with 3 young top Tennis Canada players, and now I got a whole bunch of them. I've got 16 of them following through. So it's pretty interesting.
Let me know, are you using Podiarco, either capsules or tea, as an adjunct? And have you been doing anything like that as far as besides hands-on approaches?
No.
If not, I suggest you give that a try and see if that adds anything, and let me know.
I will.
Would you?
I'll definitely let you know.
Yeah, that'd be great.
Excellent.
The only downside to Podiarco is you pee more often. You know,
that could be a problem.
Well, I understand that, but I mean, you have to warn people that, you know, they have to plan for the fact that their urinary system is going to get jump started, you know, by that. But again, if they feel better, they have less pain, and if they
It should be
perform
called
better,
potty. I gotta go.
I don't think it's just about pain. It just enhances their performance, John.
What's that?
I don't think it's just about pain. I think it just enhances their performance.
Yeah,
You know,
enhances the
they do
performance.
perform.
Yeah. Have you, Alan? Does that fit with anything that you've had experience with?
I don't know about. I mean, I assume that's true with the lymphatic pumping. I know just PRRT in general improves performance.
Yes.
I mean, if you can get people just aligned, and Danny gave me my first session, and I felt like I was all greased up for about 2 months. So, I mean, I had never experienced anything like it before. I mean, it was like I went through a car wash, and I was put back together kind of normally again, and that was pretty important for me. But I think
Danny, I think that was a compliment, even though it had sounded a little different here.
You know, but I would say that one of the cool things about PRRT is that because we're regulating or re-regulating a dysregulated nervous system, instead of calling it, you know, overexcited or upregulated, I like to call it dysregulated, and that's because sometimes it's too low and sometimes it's too high. And when we provide the stimulus, it really puts it back towards a baseline level. And it's really good with athletes because they don't want to be sedated before they play, and they don't want to be over-energized before they play. And so PRRT kind of puts them in that re-regulated state, in a normal regulated state. And I think that's why they like it so much, is because you're not going to get any of those side effects. They're not going to feel sedated. They're not going to feel amped up. So really well positioned for it.
Yeah, good point. Good point. Eric, do we have anything else?
I was gonna open it up. We've been on for about an hour and 15 minutes now. So
Oh, wow.
yeah, I was gonna open it up to any other questions.
Should do this more often.
Yeah, I agree. I agree. Should this more often.
Well, I don't.
Good.
We haven't lost anybody yet, have we? Huh?
No.
Oh, yeah.
That's good. That's a good
I mean,
sign. Yeah.
are
Probably-
there any?
The reason you're probably still on is because you don't have any patients. That's probably why you're still sticking up the call here. 'Cause you got nothing that you can do that's earning you any money. Anyway, go ahead, Eric. What were you saying?
I was gonna open it up and see if there's any other questions before we call it a wrap for this session.
I have a couple.
Sure.
They're very divergent couple questions, but so the first one maybe is more technically oriented. I work with a lot of people who've had strokes, and I'm finding that even when they can't use a side of their body, that PRRT actually still gives a lot of benefit. And I'm just wondering what other people's experience is, and how you go about working with someone who's maybe is, has lost use of one side of their body because of stroke.
Anyone want to jump in on that? I don't see stroke patients, even though I did my master's thesis on energy cost ambulation for people with stroke. And I can tell you that it takes a lot of energy for people who've had a stroke to walk.
I haven't done anything with stroke, but I've done with cerebral palsy. With having the same kind of response you've had with a stroke patient, where they do have a benefit from it. It's not a long-lasting benefit, but they do feel better with it. From improved sleep to less decreased tone. So it's not one of those things that you can say for no more, because they do come back. Once I see a cerebral palsy patient once every 2 weeks, and he seems to be happy with that. That's the best I can give you on that. That's my input on that. But primarily cerebral palsy. That's what I work with.
Tom or Danny, do you have any experience with stroke patients?
I have the same experience that was just mentioned. You're going to get some temporary relief. It's good for pain control. Again, temporary pain control. I think that the old adage, you need a healthy nervous system to have good, permanent results, and they just don't have a good, healthy nervous system.
Mm-hmm.
Actually, sorry, can I jump in? I've had few patients with stroke, and you guys mentioned cerebral palsy, even though, yes, that's both affects the nervous system, but cerebral palsy is different than someone with stroke, because someone with stroke, there's a chance of complete recovery, or at least major recovery compared to cerebral palsy. So one of the things, like I've had a patient that had a stroke during childbirth, and she was actually in a coma for 3 weeks. And then when she woke up, she couldn't lift her right arm. So one of the things in a Russian medical massage, we use inhibitory regime as soon as, we have a stroke protocol, but there is also one of the main techniques we use, it's an inhibitory regime, because you want to stimulate, if there is any pathways in the synapses that are damaged, specifically permanently damaged, you want to create new pathways as fast as possible and as soon as possible.
Yeah.
So I usually recommend patients, if, especially if they're in a hospital, like I've had patients that their parents were able to get me into the ICU, and I would start working on them right away. And I would actually hand some type of a paperwork, what I'm doing, so doctors can see it, can put on their file. So that's one of the things, combining with the PRRT. Also, one of the things you want to look into, Dr. Kurik at the Kurik Institute. He has some really, really cool videos on some techniques to do with stroke patients. So just look into that.
Maybe later put this into the Facebook group. Just, if people have mentioned someone's name or a website or something, if you could add them there so that that's a resource.
Yeah, or I'll send it to Eric.
Yeah.
Okay, great.
I've been trying to take notes along with all this, but I'm sure it's just a jarbled mess. But I'm recording the video so I can share it with everybody else, and I'll try to put my notes together into some sort of coherent thought. So, are there any other questions, guys?
I had that second question,
Sure.
which is, so some of my colleagues have, everybody has a mishmash of different techniques that they use, PRRT being one of them. But some people who haven't been able to, physically work with people are moving to doing things remotely. And I'm wondering if there's any opportunity for that with PRRT, to do, video work and show someone what to do, or, trying to think creatively and still finding ways to help people.
Yeah, I use a fair amount of PERT in my distance sessions. Some of that, most of the time I'll meet on Zoom, so I can show them what to do. Sometimes when you're trying to do a reflex, there are ways of getting the reflexes to work as well. I try to get them to relax and think as if they're not in their body, and then hit the reflex. And you can get a pretty good reflex that way. But if they're thinking too well about it, then, or if they're thinking about that area, you're going to inhibit the reflex. And so I always try to tell my students and clients and things to try to surprise themselves, and that works pretty good. You can also, what's interesting about this is you can also do this energetically. That you can do your release on them laying in front of you while they're not there. And I guarantee you'll get the same results. And it's fascinating, right? Because you're just releasing an imaginary person laying in front of you, but you can actually feel the tissue. We have in our program, we have a chiropractor, and I challenged him to do to find one of our students he did an evaluation of their spine, and he had these 3 manipulations he wanted to do. And so I asked him to evaluate, and we all evaluated the person. And then we had him manipulate a teddy bear that he had cloned into that person. And when we reevaluated the person was completely different after chiropractic manipulation of the teddy bear. So you're really limited by energy is not limited. Einstein knows that, right? We're limited by how we perceive the limitations that we have. And once we realize that there's no limitations and there's not so much a thing as time and space, then really just getting out of our own way and being creative. And the same exact thing, like most of you, I guarantee you, most of you know how that test is going to come out before you do it. Or as you're doing a release, you can feel the release before the tissue actually releases. Right? How many of you would say that you can feel the tissue release before it actually releases on your fingertips?
Yeah.
Right? And so all you're doing when you start the distance work is you're going into that same place, and you're just tuning into that and imagining if I was helping them release. And then the proof of the pudding is in the eating. You just recheck it, have them recheck that motion.
Well, Alan is totally talking my language. My dog ears went, what? That's my whole business model. And one of the things in this stretch of time is, if I am the practitioner who is teaching people who are holding onto their money, who we can't be 6 feet near, I don't ever have to be 6 feet away from or near. I can work all the time. But if I'm a practitioner who is providing information, helping them over the stretch when they are super upregulated, really tight, I'm going to be the first call when the job gets reestablished, when there's excess money, when things reestablish themselves. But I can be really helpful building a marketing strategy in my list and my business now, just probably more easily than normal times.
And to take what you said and maybe to put a little different spin on it, It's a great opportunity to stay in touch with your patients in some way, shape, or form during this time. I don't think your competition will, to the extent that you could, even if it's just, and you don't have to get on the phone with them. You know, you could just have a short little message that you send out, and you know, they're going to appreciate that because they're not going to be hearing from other people in the medical field. It's not likely that they're going to have competitive messages reaching them, and you're showing a concern, very much like why we're having this get together. Is I'm wanting to do something for you folks in the same way that you can do something to reach out to your patient population and let them know you're thinking about them, and anything new that you're working on, and new strategies and new approaches. And you know, if you haven't marketed at 3 and 30, as things start to turn around, that would be a way to start having people understand that you're going to have a feature to your practice that your competition won't have. Okay. Okay, so should we, Eric, should we call it a wrap? No?
Yeah, I was gonna say a show of hands. Would you guys like to see this kind of stuff continue? Maybe we could do different topics and.
Definitely, I'm on for
Yes.
that. Yeah, that'll be great.
Cool.
Yeah, definitely. Very much would like it.
Yes.
Good. Well, Dan, you didn't get to lead us with an opening prayer. Do you want to lead us with a closing prayer before we say goodbye?
Yeah, let me do that. All right. Father, we ask that you be present in our lives, that you keep our health and those who are close to us, those that we love and cherish to be in our life. We ask that you keep us healthy and that we can be present for our patients' needs as soon as possible. And during this time, we can continue to learn, to grow, and to appreciate the body and the brain and the nervous system that you've gifted us with. And we ask this in your name, amen. All right, thank you all. I so appreciate this. We've never done this before, and I feel like this has been a great sharing of ideas. I want to go back and listen to a lot of this because there's so much in here that I think we can all benefit from. And if it's something that you would like to do again, just be in touch with Eric and he'll funnel that information to me, and we'll see if we can get a schedule of another meeting. Okay.
Awesome. Thank you, everyone.
Everybody stay well.
Thank
Thank
you.
you.
Stay well. Okay.
Thanks, guys.
Thank you all.
Take care. Bye.
Talk soon.
And stop
All right,
licking
guys.
door handles.
Wash your hands.
Just for now. Just for now.
Wash your
You
hands.
can still eat dirt, but don't lick any door handles.
Wash your hands, though.
Thanks again, guys. We'll talk soon.
Take care.
All right, guys.
Bye-bye,
See ya.
everybody.